be able to see this on demand on the carp.ca website. And that will be uploaded tomorrow as well. You're going to hear me twice. And while I close that. All right, so we are now live streaming on YouTube. And in the Zoom, I will record this to our system. And now that we have hit the top of the hour, I am delighted to welcome all of our CARP members who are tuning in via Zoom for this virtual CARP webinar, an ongoing series of informational and educational events that we share with our CARP members from coast to coast. My name's Anthony Quinn. I'm the Chief Community and Benefits Officer at CARP and delighted to be bringing you our special guest today, Dr. Ron Grossman. And by way of biography, Dr. Grossman is a professor of medicine at the University of Toronto, previously the chief of medicine at Credit Valley Hospital in Mississauga, and many interests over his long career have been in the respiratory tract infections, if that's correct, doctor, and you maintain a specialist in internal medicine and respirology. So lots of background on this important topic that we're discussing today. We've convened this meeting to bring our members the most up-to-date information on the viruses that are spreading through our community, particular emphasis on influenza, get the latest news on COVID-19 for our members, as well as a number of other important updates and things to be aware of that are available to protect yourself as we go about our business in life today. So welcome, Dr. Grossman. Thank you very much for joining us this afternoon.
My pleasure. Happy to be with you.
Thank you. Now, the first thing I'd like you to respond to me and to our audience is we are, if I look at my calendar, 13 days until Christmas Day here, and I think December 18th is the beginning of Hanukkah, and a number of other reasons why we'll be celebrating together. We'll be in closed spaces. We'll be close cheek by jowl with our friends and family. What is your top message for our members as we prepare to enter into this holiday season?
Well, first of all, best wishes to everybody in the holiday season, and I hope you really do enjoy the holiday season. But the message is you have to be somewhat careful. The CARP audience is in general a higher risk audience just because of age alone. And we know that all of these respiratory pathogens, viruses and bacteria and whatnot, are all more likely to attack individuals who are older. And the rationale behind that is very straightforward. As soon as you hit the age of 50, your immune system starts to weaken, and it progressively gets weaker as you get older. Nobody can escape this. This happens to everybody. So those of us who worked in hospitals over the decades, and literally I've been working for decades, if you go into a hospital ward around Christmas or shortly after Christmas, it's filled with people who have respiratory tract infections, and you don't see 25 and 35-year-olds, you see 65-year-olds and 75-year-olds. So fundamentally, age is the biggest risk factor for any of these respiratory pathogens, whether viruses or bacteria. That's the first message. And the second message is, more or less, you have to build a moat. You know, if you're in a castle, you are the castle, and it would be very helpful to build a moat to try and keep some of these offending pathogens away from you. And there's a number of ways that you can do that. Some of them are simple, some of them a little bit more complicated, some of them are really personal, some of them are generalized. And we can go through all of these recommendations, but fundamentally, the notion is individuals who are older, particularly over the age of 50, and especially once you get past 65, you're at risk. You're at risk from infections from people who come in contact with you, and keeping some distance from them is important, but living a life and enjoying your family is really important as well. So life sometimes is a compromise. You have to pick and choose what you're willing to do and kind of sort out the ways you can protect yourself at the same time.
So protecting ourselves has gone from a public health government policy mandate over the last few years of COVID to an individual decision. but our members may have been sent into isolation for fear of what the news and public health messages were coming out over the last number of years. But we've had breakthroughs in vaccination, and we've learned a lot more about how the COVID virus spread. So can our members, if they have had the protection of vaccinations and boosters from COVID, and hopefully their flu shot as well, can they confidently make that assessment based on their own health if it's okay to go out and see their family and their grandchildren? Where does public health now give that message to members to go out or stay in?
I think the message is be careful, but don't go crazy. Don't be crazy about this. So be careful means in enclosed environments, particularly a lot of people, wearing a mask makes a lot of sense. It's not perfect. It's not going to protect you perfectly, but it gives you some level of protection. Obviously, distancing helps as well. Not going into these crowded environments helps. But I want to come back and talk about the grandchildren, if you don't mind.
Sure.
Because at the end of the day, it's the grandchildren that are the purveyor of disease. And in the natural scheme of events, the grandchildren are really trying to kill the grandparents. That's kind of how it plays out. And I keep saying it's all about the money. They really want the inheritance. They want to knock off the grandparent. So here's how it kind of plays out. So let's talk, for example, I'll give you a really good example. The commonest cause of pneumonia is a bacteria called the pneumococcus. So pneumococcal pneumonia is the #1 cause of bacterial pneumonia in adults. And the way this works is that the organism resides in the back of the nose and throat of little infants. It isn't anywhere else. It's not in dogs, cats, rats, mice, anywhere else. It's just in the back of the nose and throat of little kids. Now, the little grandkids love to share their secretions. You know, if they're in a daycare center, they're going to share them with other kids in the daycare center. So if you sample the back of the nose and throat of kids in a daycare center, at least 50% of them will be harboring this bacteria. Now, what happens is the parent comes into the daycare center, picks up their child, hugs and kisses them the way they're supposed to, and the little child shares their secretions with the parents. But the parents are at the prime of health. They're usually in their 30s, maybe their 40s, and their immune system is really intact. And even if they acquire the bacteria from the child, the chances are the bacteria hangs around maybe for a week or two, doesn't really cause disease, and the immune system of the parent will eradicate the bacteria. The problem is actually the grandparent. So when the grandparent picks up the grandchild, the hugs and kisses them, the grandchild wants to share their secretion with the grandparent as well. And that happens all the time because you love to hug and kiss your grandkids. Because believe me, I'm a grandparent, that's a wonderful thing to do. But they share their secretion with the grandparent. And the grandparent immune system is not quite what the parent's immune system is. And so the grandparent may acquire the organism and have trouble clearing it. It doesn't do anything. It just kind of hangs around in the back of the nose and throat of the grandparent. And it really doesn't cause any trouble at all until the grandparent gets flu or a head cold or a coronavirus or any of these viruses. And when you get that virus, it damages the defenses of the upper airway. And the bacteria, which was pretty comfortable not doing very much, kind of hanging around, all of a sudden has an opportunity to get into the lung and wreak havoc. So the way it works for older folks, particularly with bacterial pneumonia, is they usually acquire the organism from the grandchild, and it takes a preceding viral infection to trigger the pneumonia that ensues. And pneumonia in older persons is a serious disease. It's got major implications for your health immediately and even long term. So, yeah, I mean, there's a couple of ways you can kind of protect yourself. One is get rid of the kids, kill all the kids, you don't get exposed, no problem, right? I don't think that's going to be a very satisfactory solution. But the other way of doing it is vaccinate the adult so that even if they do get exposed from their grandchild, they're much less likely to get disease. So at the end of the day, it still comes down to personal protection. You don't want to isolate yourself from your family and particularly your grandchildren. That's the joy of getting older, is to see and play and interact with your grandchildren. But as I said, they're the purveyor of disease. They're the ones that are going to try and knock you off in the long run.
And that bacteria in the children is not affecting them or displaying any signs?
No, not necessarily. More often than not, they're just being carried in the nasopharynx of kids. Their kids are not sick, so they can be healthy. But the problem is they're coming from these daycare centers. They almost always have some sort of running infection, some viral thing, and the snot's dripping out of their nose, and they're just going to share that stuff. That's the problem.
So let's go through then what's available now to Ontarians from their doctors or pharmacists or elsewhere.
So first of all,
what are those levels of protection?
Okay. So, individual protection is vaccination, obviously. It's a magnificent scientific time. We are developing new vaccines all of the time. The technology is changing very quickly. And the vaccines that we have today are quite a bit better than the vaccines even 4 or 5 years ago, or even 2 years ago. We have better vaccines. I don't want to particularly get too much into COVID because that's obviously a changing scenario. We can talk about that if you wish, but I want to talk about influenza, pneumococcal vaccination, and ultimately something about RSV. So influenza is the one that's really active now. So for 2.5 years, we had no influenza. So when people were staying home, shut-ins, wearing masks, not in contact with anybody, influenza disappeared. And the same could be true if you really wanted to be isolated and don't see anybody. You're not going to get influenza. But as I say, that's not a life for anybody, I don't think. So influenza's come back this year, and the season has started early. It initially was attacking children, and it's now hitting adults. The influenza virus, maybe I can branch off, talk a little bit about the virus itself. The virus, there's 3 forms of influenza virus. There's an influenza A, an influenza B, and an influenza C. Forget about influenza C, it's not important. A and B are the important ones. And of the pandemics, A is the most important. And A tends to occur early in the season, B tends to occur later in the season. So when it comes to A, there's some variants of A, which are named after proteins that are stuck on the top of the virus. These proteins allow the virus to attack cells and to escape from cells. And the terminology is H and N. So H is the hemagglutinin protein, which allows the virus to stick to a cell. And the N is, the details of all that aren't terribly important. The issue I want to make, or the point I want to make, is that the influenza virus this year is an H3N2 virus, which tends to cause more serious disease than the other one, which is called H1N1. So we're seeing more serious disease. But the good news is this year's vaccine is a good match for the H3N2 influenza virus. What we've learned, because of the weakness of the immune system of people as they get older, they need a more vigorous vaccine to afford protection. So for individuals over the age of 65, it is strongly recommended, urged appropriately, that people over the age of 65 receive a high-dose influenza vaccine. They're the only ones for whom we introduce these high-dose vaccines. And the problem is, if an individual over the age of 65 gets a standard dose vaccine, it can still work, but the efficacy of the vaccine in someone over age 65 is about 20% lower than if you're 45. And with a high-dose vaccine, the efficacy is brought up to the level of the standard dose vaccine in someone whose immune system's intact. So high-dose vaccines for people over the age of 65, everybody recommends that without exception.
So it's not only better than having no shot at all, but it's better than the standard dose, which is recommended for people under 65.
That is correct. That is correct. The other thing that's relatively new. The high dose really came out last year. This year, we also have another influenza vaccine that's come out made very differently than the standard vaccines. And the new vaccine it's called a recombinant vaccine, is developed in a very different manner. So influenza vaccines are developed by taking the strains that the WHO recommends at the beginning of the season. By the way, the WHO decides what the vaccine is going to look like. The WHO looks at what's going on in the Southern Hemisphere and then predicts what's going to happen in the Northern Hemisphere for our winter. Sometimes they're right, sometimes they're wrong. More often they're right than they're wrong, but they don't always get it, correctly. This year, it looks to be pretty good. Anyways, the WHO says we want 2 strains of A, 2 strains of B to make up the vaccine. So what they do is they grow these viruses, these 4 strains, in eggs. So they can generate millions and millions of these viruses as they grow in eggs. And at the end, they isolate the viruses, denature them, make sure they're not active. All you get is the antigens, not the actual virus. And that ultimately ends up being the vaccine. The problem with that process is that the end product of the viruses growing in the eggs is not exactly the same as what the WHO wants. There are mutations that occur as the virus grows in eggs. So the purity of the vaccine at the end of the day is not exactly what it should be. And that probably affects efficacy. So a brand new development this year is there's a new recombinant vaccine that's being recommended. It's approved by the federal government, so it's safe and effective. And the evidence is that it's about 30% more effective than the standard dose vaccine. And is being recommended really for people between the ages of 50 and 64. Not paid for yet because it's brand new and they need more data before they end up paying for it. But this recombinant vaccine looks very good. And that's brand new technology too. So we have high dose for people over the age of 65. We have this recombinant influenza vaccine for the 50 to 64 group, which looks to be better than standard dose vaccines. And I'm spending some time talking about this because it's really reinforcing the notion that science is developing newer, better vaccines with better protection as we go forward. And this is the beginning. The technology just moves on. Nothing stays the same. Thankfully, we're getting better at this.
It's great. So from the patient point of view today, if someone hasn't had their vaccination for the flu, for influenza yet, they can go to their doctor or pharmacy. If they're over 65, they will likely be given the high dose that suits them. They won't likely be offered the recombinant one unless they're asking for it, I imagine.
No, the recombinant one is not really approved for over 65. It was really tested in people under the age of 65. It always was developed for that age group. So the best vaccine for senior is the high dose. No one's going to argue with that. That's a very strong recommendation from the National Advisory Committee on Immunization, and I don't think anybody's going to dispute that recommendation. But the new recombinant one is an option for people under age 65, probably from 50 to 64, and it looks to be better than the standard dose vaccines. But as I say, because it's new, there's only one good trial that's demonstrated its efficacy against the standard dose vaccines. The government is reluctant to pay for anything at the best of time. So there's almost always a delay.
We are lucky in Ontario that the province, and through a lot of advocacy work on behalf of CARP, that the province of Ontario does pay for that high dose flu shot. In other provinces and other jurisdictions, it's an out of pocket expense. So take advantage of that opportunity.
It's crazy that it isn't covered. I mean, the implications of influenza in somebody over the age of 65 is quite profound. I mean, it's one of the leading causes of hospitalization. It's a leading contributor to mortality in people over the age of 65. It leads to cardiovascular events, depending on how sick they are. I mean, some really bad things can happen to get influenza, and it's hard to believe it's not a cost-effective measure. I'm all for it. I mean, any jurisdiction that's not paying for a high dose for the elderly, I don't think they're making a lot of sense. I think it's crazy, actually.
A question just came in. If someone has already had the standard dose, can they get the higher dose vaccine if they're over 65?
Sure. Why not?
In the same year?
Yep.
Yep. Okay. And if someone arrives at their pharmacist or their doctor's office and they only have the standard dose in stock, should they hold off, or is a bird in the hand better than two in the bush?
I believe a bird in the hand is worth two in the bush, frankly. Something is better than nothing. Nothing is no good at all.
Right.
And you only need one episode of influenza. I mean, anybody who's had influenza will tell you it's like being hit by a truck. It can be quite bad, particularly in older individuals. And if you've got significant other illnesses, particularly chronic lung disease, chronic heart disease, diabetics, it can be really quite nasty.
And as I mentioned, the dates towards the Christmas holidays and the break, it's about 2 weeks away, and I understand that's about how long it takes to get the full efficacy of the of the vaccine, so there's no time like the present.
Correct. Today.
Today's
the latest tomorrow. Get moving.
Wonderful.
Get it done. So the other thing is, we've learned that you can co-administer vaccines the same go around. So for example, I'll come back and talk about pneumococcal vaccination a bit later, but you can get a pneumonia shot in one arm, the flu shot in the other arm at the same time. I mean, it's twice the pain, but you get it done. And these vaccines, for the most part, are really very well tolerated. I mean, it hurts to get a needle. I'm not disputing that, but beyond that, it's really pretty safe.
To use a second bird metaphor, then kill two birds with one stone. One visit to your pharmacist or your doctor, and you get both.
One of the problems, particularly as you get older, people have diminished mobility, and organizing a trip to a physician to get a prescription for a vaccine, then going to the pharmacy, and maybe having to pick up the vaccine and going back to the physician to get it injected if the pharmacy doesn't want to do it. That's kind of a major undertaking for some people. So if we can simplify matters and combine vaccines, get them done at one shot, well, obviously two shots, but at one go round, I think that would be quite helpful. There's a little bit of planning that goes into that, but it can be done that way.
Now, we had a wonderful response to this webinar, and lots of, I think there was 700 odd people that signed up to register for attending. But we did have
the more the merrier.
Yeah, the more. But we had a few who said, "Listen, I'm in my 60s, I'm in my 70s, and I'm healthy. I take no medications. I have a strong immune system. I don't believe in vaccines." And this has been an ongoing response from a minority of folks. But you're not sick until you're sick is what I tell them. What's your professional opinion on that?
So, let me talk a little bit about pneumonia, because we have a very good vaccine now for pneumonia, bacterial pneumonia. So if you're over the age of 65, I don't care what your underlying health is, and you get pneumonia, bad luck, you just came in contact with somebody, your grandchild brought in the organism, you got a flu-like illness, and off you go, you have now bacterial pneumonia. If you are sick enough to be hospitalized with your pneumonia, which is very common in older people, as I said, the wards are filled with people with pneumonia, the chance of you having a significant cardiovascular event is in the range of about 15%. Now, what am I talking about? You come into hospital with pneumonia, and when you're in the hospital, you get a heart attack, or you develop heart failure, or you develop a significant cardiac rhythm disturbance. The odds of one of those events occurring is about 15%, which is very high to get a heart attack. And this is individuals who don't have heart disease, don't have anything. They just come in, have pneumonia, and about 1 in 8 will develop a cardiovascular event in a hospital in 30 days. Not just that, if they survive their pneumonia and go home, you follow them for 2 years, the risk of having a cardiovascular event is doubled for at least 2 years. So pneumonia is a precursor for a cardiac event, either a rhythm disturbance, a heart attack, or heart failure. The same, by the way, is also true for influenza, but it's not quite as profound as for pneumonia. On top of that, if you again develop bacterial pneumonia, get hospitalized, the 30-day mortality rate, your chance of dying in the month, is in the ballpark of about 12%. So about 1 in 10 will die of their pneumonia, independent of whether they have any other illness. And the cause of death in these individuals is not overwhelming infection. That's not what kills them. It's actually the heart complications that kill them. So not getting pneumonia makes a huge amount of sense. You don't want to be hospitalized. You don't want to run the risk of dying, and you don't want a risk of these cardiovascular events. And we're learning a lot about these cardiovascular events in relationship to how severe the infection is. The more severe the infection, whether it's influenza, COVID, bacterial pneumonia, it doesn't matter. They're all the same. They induce a profound inflammation in the body. That's the response of the body to this pathogen, whether it's a virus or a bacteria. And the more profound that inflammation, the more likely the risk of having a cardiovascular event. It's the inflammation that triggers a lot of these events. And we think all of this could be avoided, delayed, whatever, if you don't get the infection in the first place. And the only way you don't get the infection is either you build a castle with no drawbridge. Nobody can get to you, so you can't get an infection, which is, I think, a very unsatisfactory lifestyle. Or you protect yourself. And we have vaccines that clearly are efficacious. They're not perfect. No vaccine is perfect, but they clearly reduce risk of these various infections. I don't know. To me, it's like a no-brainer.
Yeah.
You want to help yourself. You don't want to get sick. You don't want to get a heart attack. You don't want to die. So help yourself.
In previous educational events about the high-dose flu vaccine that we've had for our members, the previous physicians had mentioned that there is an anti-inflammatory response from the flu vaccine. So it's not the number one reason to get a flu shot, but it also lowers your risks of having a heart attack after you get your flu shot.
Very interesting study I'll share with you briefly that came from Copenhagen. So this is the Copenhagen City Heart Study. It's a group. They've been following patients in Copenhagen with heart issues for a very long period of time. This is a study of thousands of Danish subjects who had heart failure. And they looked at their death rates over a series of number of years in relationship to the number of flu vaccines that they had received. So if they had received no flu vaccine, let's say they had X number of deaths, let's say 10% mortality over the observational period of time. If they had one flu vaccine, their risk was reduced by about 6 or 7%. If they had vaccines 2 years in a row, the risk was reduced by another 4 or 5%. And if they had vaccines 3 years in a row, it was reduced even further. So multiple vaccinations appeared to afford some protective effect against deaths in individuals who had very bad heart disease. And while it doesn't make a lot of sense just off the top, there is a potential explanation for this that makes it biologically plausible. I kind of mentioned a few minutes ago that the thing that really kills people is this inflammatory response. When you're exposed to a virus or bacteria you've never seen before, the body goes crazy. It's trying to get rid of it. And it induces this powerful inflammatory response to try and eradicate the pathogen. But that inflammatory response actually hurts you. It can damage your heart, it can damage your lung, it can damage your kidney, it can damage your liver. When you're exposed to a pathogen in small little bits, the immune system sees it and has some experience with it. So when you actually come down with the flu or bacterial pneumonia, and your body has seen something like this before, the body doesn't go crazy. You don't have this crazy inflammatory response, which kills you. So there is this mechanism by which multiple exposures to small little bits of bacteria or viruses, whether in the form of a previous infection or in vaccination form, blunts the body's response, this acute response to when you're exposed again. So it actually makes quite a bit of sense that multiple vaccinations offer protection against really bad outcomes. And I'll give you an example. The use of the pneumonia vaccine has been demonstrated to reduce your risk of being hospitalized and dying from COVID, even though the vaccine has nothing to do with COVID, but being vaccinated seems to offer some sort of protection. I think it's this blunting of the immune response, this crazy inflammatory response that occurs when you're exposed to something you've never seen before.
I just wanted to go back to a question that I saw come in, and it was when you mentioned that the WHO looks to the Southern Hemisphere for our flu shot recipe. What do they do for the following year for those in the Southern Hemisphere? Do they look to North America and see what actually happened?
Yeah, of course.
So yeah. Okay, there's a cycle.
So, yeah, it goes back and forth. But the problem with influenza virus is that in its very nature, it tends to mutate very frequently. So what happens is that the proteins on the surface of the virus change through this mutation process. That's a process called antigenic drift. So it's drifting into a new virus, which is why the vaccine has to be altered every year to kind of catch up with what the virus is doing on its own. This has nothing to do with our immunizing people. This is the inherent property of the virus itself altering itself. So that occurs all of the time. So that when we develop a vaccine, it may be effective against the virus that we've previously isolated, but I can assure you it will not be terribly effective against next year's virus because the virus is not the same, it's altered. There's another process that can go on with influenza viruses as well, something very different. You got a minute? I can spend a minute talking a little bit.
Please, we got some time, yes.
But this is kind of interesting. So influenza viruses are native to wild birds. They will live in wild birds, not domesticated birds, but wild birds. And wild birds have migration pathways. So one of the major migration pathways of wild birds is from the southern hemisphere to the northern hemisphere, and it goes over China. That's a pathway. So from the southern hemisphere to the northern hemisphere, and it goes right over China. As these birds are migrating to the north, they poop. And in their poop and excretions are these viruses, which are living in these wild birds very comfortably. They don't cause disease in the wild birds. So when this poop hits the ground, remember, it's going right over China. So it drops into southern China. And then domesticated birds, so ducks and geese and chickens, may be exposed to these viruses by drinking the water where the poop's gone, basically. The domesticated birds get sick. And if you're a food handler, you get sick. So influenza viruses often begin in southern China because this is the pathway. This is where it's all happening. Then if you have a bird, a domesticated bird that's infected with this avian virus, and you have another animal that may be infected with a human virus, let's call it a mixing chamber. If these two viruses come together, you can come up with a brand new virus that has elements of the bird and elements of the human virus. So in nature, the mixing chamber tends to be a pig. Pigs can harbor human viruses, influenza viruses, and pigs can harbor avian influenza viruses. And if the two come together in a pig, you end up with a brand new virus. That's when you get a pandemic, an influenza pandemic. So every year through this process called antigenic drift, the virus changes a bit. So we have to keep chasing our tail to keep up with it to give you a new vaccine every year. But every 10, 20, years, decades, every once in a while, you'll end up having this what's called antigenic shift, which is the mixing of a bird and a human virus in a mixing chamber, usually a pig. You end up with a brand new virus that human beings haven't really seen before, and you get a flu pandemic. So you'll recall the 1918, 1919 flu pandemic. There's one in 57. There's been a couple of them over the decades. And some of them have been really quite severe.
Well, I think we in my generation hadn't experienced a pandemic until COVID, and we see how quickly viruses can mutate and change, and we're hearing a new instance almost every week in the news about how quickly the viruses have changed. But as you mentioned, science has done wonderful things to keep up with these changes. And in our pre-call, you mentioned that there is something quite amazing on the forefront of stopping pneumonia spread. So can you tell me a little bit about the new vaccine there?
Right. So the commonest cause of bacterial pneumonia is an organism called the pneumococcus. Its proper name is Streptococcus pneumoniae. You don't have to remember that, but everybody calls it the pneumococcus. So pneumococcal pneumonia is the leading cause of pneumonia in individuals throughout the world. The incidence varies. In Spain, the number is as high as a third of all pneumonias, pneumococcal pneumonia. In Canada, it's around 15% is pneumococcal pneumonia that we know about. And we almost certainly underestimate the prevalence of this organism. So it's the number one bacterial pathogen, and it's the one that causes the most serious disease. It's the one that's usually associated with hospitalization. It's associated with the development of septic shock, and respiratory failure, and death. So it's not a good player. So everyone thinks it's one bacteria, but it's not. There's 100 variants of this bacteria. 100 have now been identified. The vaccine that we had up to now was a vaccine called Prevnar 13, which offered protection against 13 of the 100 variants. The one that's just come out as of August of this year is called Prevnar 20. It offers protection against 20 of the 100 variants. 20 out of 100 doesn't sound so good. How good could it be? Well, it turns out to be pretty good because those 20 variants make up more than 80% of the infections in humans in Canada. So we think it's quite a good vaccine. And it's, again, one shot and you're done. There are no boosters. You don't have to do it again. Just get one shot. NACI, the National Advisory Committee on Immunization, is currently circulating a document where they're about to release it with their recommendations for pneumococcal pneumonia prevention. So it's not official yet, but I could assure you they are going to strongly recommend Prevnar 20 as a standalone vaccine, as the vaccine of choice for people over 65 years of age or older to prevent pneumococcal pneumonia.
Has it already been approved and recommended in the USA? I know that we
Yes.
tend to follow a little bit behind there.
Yeah, Canada is sometimes very funny about these things. This time, NACI is actually pretty good. So in 2014, there was an enormous study that was sponsored by Pfizer. It was done in Holland called the Capita study that demonstrated for the first time that there was an effective vaccine to prevent pneumonia. And that vaccine was Prevnar 13. Within 6 months, the CDC changed the recommendation, said everybody over the age of 65 should get Prevnar 13. Canada didn't do anything, didn't say anything for almost 3 years. It's like unbelievable. The data was there. CDC had already made the recommendation, and NACI said nothing. I was appalled. I mean, they weren't saying a word. Then eventually they came around and said, yeah, it's probably pretty good. This time's a little bit different. So when the immunologic data from Prevnar 20 became available, there's also a Merck vaccine, a 15-valent vaccine, but the 21 looks to be, the 20 looks to be better. Anyways, when that immunologic data became available, once again, the CDC very quickly changed the recommendations. In early January, they did this. And we're delayed compared to the CDC, but it isn't 3.5 years. It looks like it's going to come out very shortly, the recommendation. They're going to say everybody over 65 should get it. So this year, this time around, the delay is a little more reasonable. Should be any, but anyways.
Well, that's wonderful news for our members, and CARP's advocacy, not only with educating our members, is to ensure that these advancements, these best-in-class vaccines, are available to our members, and oftentimes our members will respond in a way that some of these out-of-pocket vaccine costs are nice to have rather than must-haves.
So let me make a point about this.
Yeah.
Well, I want to make a point because NACI, for the first time, is also looking at cost effectiveness. And my read of the document that's going to come out is not only they're going to recommend that people 65 years of age or older get the vaccine, they're also saying it is cost effective. Now that puts an enormous burden on the provincial health authorities to approve it. I mean, it's not only better, it's cheaper. So it's kind of hard to believe that health authorities are going to hold back and not pay for it. I mean, trust me, they're not going to do anything for a year, unless people like you, CARP, get on their case and bug them all the time. If you have the National Advisory Committee saying it's better and it's cheaper, how can they not pay for it? I mean, I put up my hands. I mean, they won't pay for it for a while anyways, but it seems to me that if actually NACI says this and they're going to be quite definitive, then I think with a little bit of pushing on your side, I think maybe it might get covered sooner rather than later. That would be a shocker, actually.
Well, we'll definitely work to achieve that. We did have a number of successes with the flu shot and with the shingles vaccines in its different iterations. The Shingrix is now the standard of care and available to Ontarians between the ages of 65 and 70.
Isn't that interesting? They approved and paid for Shingrix to prevent a rash, which may or may not be painful. The pneumonia vaccine saves lives. It's not pain. It's not a rash. It's lives. And if it's cost effective, how can they not pay for it? I mean, to me, it's just like, doesn't make any sense if they don't pay for it.
And they've improved it over the Prevnar 13. So if a patient, and maybe this is too new to ask, but if a patient had Prevnar 13 when it came out and now there's a Prevnar 20, do they get the second shot?
You bet.
You bet.
So, oh yeah, you get it. The product monograph will say wait 6 months. If you have 13, wait 6 months before you get 20. But theoretically, you can get it the next day. There's really no data to suggest it's unsafe, but it's a different vaccine. You're covering another 7 variants of the bacteria, and it's safe. There's no toxicity. The profile is very good. No different than the safety of Prevnar 13, which is a very safe vaccine.
Good. Some good news here from Nancy in our chat. It says that she got Prevnar 20 already in Saskatchewan, and it was no cost to her. So that's good to understand.
Beautiful. I got it myself, and I paid for it myself.
Oh, yeah. The chain.
Even my private insurance wouldn't pay for it. It's like crazy. But anyways,
I helped to care for my dad now, and when he was recommended his pneumonia shot from his GP, it was a visit to the GP to get the recommendation, fax the prescription to our pharmacist. We collected the vaccination on our next appointment and back to his office to have the shot implemented. So Ontario seems to have a bit of a circuitous route for getting vaccines into people's arms.
Pharmacists can actually give Prevnar 20. So but they need a script from a primary care physician. So the primary care physician can send down the script. You don't have to see the primary care physician if you don't have to want to. You just go to the pharmacy and get it. It can be done that way.
And something like Prevnar 20 or the flu shot, could those things be given at the same time as well?
100%, one in each arm.
Well,
the other thing to be aware of is something called is going to be something called replacement disease. So when you develop in the pneumococcal arena, let's go back to the bacterial pneumonia. Remember I said there's 100 variants, and this one is giving you protection against 20 of the 100 variants. Over time, nature abhors a vacuum, and some of the other variants will kind of step up and cause more trouble. So we know that's going to happen. This is the third variation of the Prevnar vaccines. The first one that came out in the United States in the year 2000 was called Prevnar 7. It offered protection against 7 of the variants. Those 7 variants caused most of the bad disease in little infants, and so infants were vaccinated. It was a wonderful vaccine, worked very well to prevent infection of the 7 variants. But what happened was, over time, some of the other variants showed up, and that's called replacement disease. And so 7 evolved into Prevnar 13. Well, Prevnar 13 has been around 8-9 years now, and we're starting to see some of the other serotypes or variants causing trouble. So Prevnar 13 is evolving into Prevnar 20. 10 years from now, there may be a Prevnar 30. There's already a 24-valent vaccine being developed. I know that for a fact, but I suspect we'll probably see a 30, 10 years from now. Things will evolve. Unless there's a dramatic change in the technology of the vaccine, what we would like to have is a vaccine that would cover all 100 serotypes. It doesn't exist. I mean, they're working on it. Scientists are looking at this, trying to develop such a vaccine. But currently, there's nothing on the horizon that I can see in the immediate future. So you can anticipate 20 will be the vaccine of choice for 5, 6, 7, 8, 10 years. And then subsequently, we'll move on to something bigger and better.
And are those changes similar to the way that antibiotics have to change to meet the changing viruses and bacteria?
No, this is completely different. So antibiotics have to become more aggressive because the bacteria changes its stripes and becomes resistant to the antimicrobial that you're offering. Here, it's a brand new organism. There's a vacuum. You've wiped out these 20 strains, and some of the other strains kind of step up to pick up the pace, but they're no different than they were before. They haven't changed because of the vaccine. It's just moving into an empty space, if you will. And that takes time. So enjoy the vaccine while it's hot and fresh and really active. You get a lot of protection. And I suspect 10 years from now, there'll be a Prevnar 30.
Well, let's hope it's a Prevnar 100 sooner.
Yeah, that
sooner.
would obviously be the best. Yeah, yeah.
Now, I've recently been, well, I'll tell you a story. There's a CARP member, he's the chair of the Hamilton, Ontario chapter, and he had a double lung transplant, and he received a treatment called monoclonal antibodies and a couple of shots in the butt called Evusheld. It's recommended, I understand, for immune compromised people to prevent and treat COVID if they do happen to receive it. But that's a very small portion of the population. What do you know about monoclonal antibodies and what they can do? I understand that children who have RSV are now being treated with a monoclonal antibody as well.
Right. So first of all, for our double lung transplant recipient, congratulations. I actually started the lung transplant program in 1984, believe it or not. And the very first successful ever double lung transplant was my patient. I picked them all. I was the one on the transplant team.
Thank you for leading that. Thank you.
Selecting all of the patients. That's another life that I led at one point. In terms of antivirals, there have been at least 4 antivirals that have been developed, monoclonal antibodies against viruses. So a monoclonal antibody is an antibody that is directed at a portion of the virus which attaches to receptors in the surface of the airway in the trachea, generally speaking, or in the lung. The monoclonal antibodies that have been developed, if given at the right time, which is early in the disease, prevent the virus from attaching to the cells and then starting its process of multiplying within cells. So timing of these antivirals is critical. It has to be done early in the disease. If it's done too late, it doesn't do anything. It's not effective. The problem with the antivirals, as they've been developed, they were developed against the original variants of COVID. And so 3 out of the 4 have lost their activity against the current variants. They don't seem to have, or they have reduced activity against the current variants. So our armamentarium against treating the viruses with these monoclonal antibodies is diminished because of the change in the virus, and the monoclonals have not kept up. Evusheld is a monoclonal antibody against the virus that has a very long half-life. So it lasts for months. So basically it's 2 shots and you'll get protection for up to a year. It has been recommended for individuals who are immunocompromised. And the rationale there was the immunocompromised individuals, when vaccinated, would develop unsatisfactory immune response. So they wouldn't be protected by the vaccines. Even if you gave them 20 shots, they just weren't going to be protected because their immune system couldn't develop the appropriate antibodies. So the notion was, why don't we give an antibody that is hanging around for a while that will more or less replace the individual's immune system? That's the idea of Evusheld, and it works. What we don't know is, does it work against the current variant, the Omicron, B45?
Yeah.
We don't know. We have no efficacy data against the current variant. So what I said before, all of these monoclonal antibodies had a role, clearly worked, if given early, but they're being challenged by the evolution of the virus itself. We haven't kept up. And
I imagine the scientists working in the lab are looking to ensure that the next iterations do meet the thing.
Sure. But it takes time to develop these things. A lot of the science is complicated and it's expensive. One of the reasons that everything went so well with COVID, with the vaccines being developed in the space of a year, was because the risk of developing these products was taken away by government. So government prepaid for everything. And in doing so, industry, which develops all these things, government doesn't develop anything, but the industry develops it, had the risks taken out. And when you take away the risks, they can invest the money and get the things done very quickly. But without that major investment up front, you wouldn't have seen the vaccines show up in such a rapid manner. And now nobody's going to be prepaying for a monoclonal antibody that may be used in a tiny proportion of the population. It's just not going to happen. So my sense is that these will come, but it'll be a sluggish pace. It won't be quick. Not the way the original vaccines came out.
Right. What I think as a society, we learned what we can do if we put our scientific mind and our investment behind it. And it's been wonderful. Sure. So I think I'll try and get to some of our specific questions, Doctor, as we reach 10 minutes till the end. The most recent question is from JJ Long, who has heard about another pneumonia prevention called PNEU 23.
Oh, Pneumovax. Yeah, well, Pneumovax is hopefully dead. So let me go back. The first vaccine to prevent pneumococcal pneumonia was Pneumovax. And Pneumovax is an older vaccine that was not terribly immunogenetic. In other words, it didn't really induce a very powerful immune response to start with. And secondly, did not induce what is called immunologic memory. And I'll come back and talk about that in a second. So when Pneumovax came out, it was never offered to children because it was never potent enough to protect children. It was only offered to adults. It was never terribly effective. It was supposed to prevent pneumonia, but it's dubious whether it prevented pneumonia at all. There are many studies that were actually negative, showing no effect of that vaccine. What it did seem to do was reduce the likelihood of having a pneumonia that spread into the bloodstream. So it would reduce what's called bacteremia. There probably was a signal there. On top of that, the protection it afforded from that vaccine was very short-lived, if at all, probably in the range of 2 or 3 years. And at one point, there was a recommendation to give a booster after 5 years, but we've abandoned that because the most boosters are not effective at all. The newer vaccine, these protein conjugate vaccines like Prevnar 13 and now Prevnar 20, are very different vaccines. They're better in terms of inducing an immune response, so they're more effective. The efficacy of the vaccine has been proven without a shadow of a doubt compared to the older Pneumovax. And finally, these newer vaccines induce immune memory. So what that means is you get the vaccine, you develop antibodies against the organism in question, the pneumococcus in this case. Then over the space of 6 months, a year, 2 years, your antibody levels in the blood go away. So you think you're no longer protected, but it's not true. When you are exposed to the organism again, your immune system wakes up and starts producing antibodies again. That's called immune memory. So the protein conjugate vaccines, such as Prevnar 20, have that property of immune memory. So that's why it's a one shot and forget about it. Whereas the older one, Pneumovax 23, never did that. So it was a poor vaccine to start with, no immune memory, booster didn't work, we've abandoned it. It's dead, it's gone, forget it. We're not going to use it anymore.
And
dead and buried, thank God.
And yes. like the Prevnar 13, you should and can get the 20. It's available to you now and would supplement that.
Yeah, so 13 is going to disappear. They're going to stop manufacturing it. So it's going to be 20. That's the one you get.
A question about natural medicines, echinacea-based antivirals, other over-the-counter. What are their value, and what do we caution people about using that natural products?
Who knows? So the problem in general about natural remedies is that there's no properly done randomized controlled blinded trials. And frankly, the nutritional industry doesn't want them. Because if you did a randomized controlled trial and you had really good science and showed it didn't work, the business disappears. So it's very much in the interest of these nutritional or other elements not to have the properly done trials. They're not drugs, so they're not regulated by government. So they can say what they want, do what they want. It's probably better to have uncertainty if you're a business than certainty have no business. So there are no trials. And if there are no trials, or not well done trials, it's very hard to make any recommendations about these. I'm not saying they're bad. I don't know. And I'll just be upfront. I don't know. You like them, you're happy with them, you think it works, be my guest. But is there evidence to say this is going to save your life? I have my doubts.
But we do have evidence on the other side for the
100%.
prescription vaccine.
Yeah.
Saw a report come across my desk late last week about Paxlovid as a treatment for COVID, and I believe now one can go to the pharmacy directly to get it and not have to see a GP, or trying to get a GP appointment. It's more difficult these days.
I just was in the paper this morning that Paxlovid in Ontario can be prescribed by a pharmacist. So Paxlovid is an antiviral. It blocks the replication of the virus in cells and has been shown to be effective. Some people who get Paxlovid, when the antivirals stop, have a rebound. It kind of reactivates. They have to be retreated. I think that's happened to at least one president. So it's not perfect. It suppresses the replication of the virus, probably doesn't kill it. But if it's not replicating, it's not going to cause an inflammatory response, you're probably going to be better off. People get better with it. Yeah.
The
problem with Paxlovid is there's tremendous drug interactions. So most people in CARP are likely have other illnesses or taking lots of medications for all these other illnesses. And it's probably not a bad idea for the pharmacist to be the one prescribing it, because the pharmacist has the record of what the individual is actually supposedly taking, and be aware of whatever drug interactions may occur. Some medications might have to be stopped. Others, double the dose if you really want it effective. So there are issues with that drug. It's not a simple drug to use because of these drug interactions. So having a pharmacist on board to identify what the potential difficulties would be, I think is quite important.
Well, Dr. Grossman, I've learned a lot. I always do, and I know our members will be thankful for your time this afternoon. Maybe I could ask you just for a summary message as we head into that holiday season about prevention, vaccination, and again, being able to kiss your grandchildren.
So overall, the message is more is better than less. The more you vaccinate, the better. So that includes influenza, COVID, pneumococcal pneumonia. And we didn't get around to it, but next year, there will be at least 2 RSV vaccines that are going to be available for people over the age of 65. So we have emerging technologies that clearly are helpful. They will help prevent disease. No vaccine is perfect. And in this coming holiday season, people have to be careful. If you're in a crowded environment, wear a mask, try to keep your distance, wash your hands frequently. Those typical health measures do seem to help. They're not perfect. Nor are vaccines perfect, but all taken together, I think, is the right approach to the holiday season. I hope everybody has a wonderful, happy holiday season and be safe.
Thank you very much, Dr. Grossman. Thank you to all of our members who tuned in this afternoon. We look forward to bringing you these webinars until we can meet again in person more often. Please stay tuned to our CARP website and check out our newsletters for the next upcoming editions of our webinars, and look forward to seeing you all again. Thank you very much, Dr. Grossman. Good day.
My pleasure. Bye-bye.
Bye-bye.